Welcome to the 8th module of this series, Incorporating Second Opinions to Reduce Diagnostic Errors. To recap from the last module, using structured templates can help reduce diagnostic errors by serving as a checklist for blind spots, commonly missed findings, and important findings that impact staging and management. There are 3 tiers of structured reports corresponding to progressively greater degrees of structure. There are several pitfalls of using structured reports, including when they incorporate pre-filled fields. Applying financial incentives are unlikely to improve adherence to the use of structured reports. In this module, we're going to describe various ways to incorporate second opinions to reduce diagnostic errors. The learning objectives are to list ways to incorporate second opinions into clinical workflow and describe clinical scenarios where double reading may reduce diagnostic errors. Tumor board is a model that already incorporates best practices for interpretation that includes second opinions, reviewing the EMR, and reviewing prior imaging. The CT example here is a 27-year-old female who presents to the ER with abdominal pain and has a large pelvic mass with liver and lung lesions. The interpreting radiologist determines that this likely represents primary ovarian cancer with liver and lung mets. The case is reviewed at Gyne Tumor Board, and a radiologist familiar with ovarian cancers recognizes that liver and lung metastases are uncommon with primary ovarian cancers, and as he's going through the exam, identifies a colon primary with adjacent adenopathy. This was a colon adenocarcinoma on pathology. Curbside consults are not a good example of double reads. In this case, a physician stops by to ask about a hypervascular pancreatic lesion on an outside study. The radiology looks at the imaging on the left and says, it could be a neuroendocrine tumor, and you can do an MRI for further evaluation. He also notices a right renal lesion and says it looks like a vascular malformation, and that's in the image on the bottom right. The referring physician leaves. The CT is repeated and interpreted by a senior radiologist with significant GU experience, who describes an infiltrative RCC with pancreatic metastasis. Pathology from biopsy of the pancreatic lesion demonstrated metastatic RCC. This is what happens with curbside consults. You're not given enough time to look at the entire imaging study and properly evaluate it, and you also don't have the opportunity to consult a colleague if there's any uncertainty. This is a CT performed for appendiceal cancer restaging. The radiologist interpreting the CT identifies a lytic lesion in the left proximal femur that was not described in the prior CT report but was present. He determines that the lesion likely represents a metastasis, but he also notes that it doesn't look typical for a metastasis. He falls prey to blind spot bias. He knows that bone metastases are often missed, and this looks like a bone metastasis, therefore he determines that it represents a bone metastasis. Follow-up X-ray is performed, and the MSK radiologist interpreting the X-ray reviews the CT and determines that this likely represents osteonecrosis rather than a lytic metastasis. The radiologist interpreting the original CT had a feeling that something didn't quite fit, and if he had listened to that voice in his head, he could have called his MSK colleague, who would have told him that this is osteonecrosis, not a metastasis. This kind of error has significant implications for patient care. This is a CT performed for staging in a woman with a remote history of RCC and recent biopsy of a nasal mass demonstrating metastatic RCC. This happened at a practice that had prospective double reading as part of their workflow. The initial reader said no evidence of metastatic disease. This double reader identified a liver metastasis in a spot where liver lesions are often missed and a subtle pulmonary embolism with pulmonary infarct. This is the value of prospective double reading. Incorporating prospective double reads has major advantages over traditional retrospective peer review processes such as RADPeer. Diagnostic errors are identified before they impact patient care. Prospective double reading may result in identification of more diagnostic errors that can be used for performance and quality improvement, and there is less potential for underreporting of errors. The downsides of prospective double reading include that it takes more time and is more resource intensive without additional reimbursement. It also often requires modification of workflow and software to accommodate the new process. This is an unenhanced CT performed to evaluate for renal cell carcinoma recurrence, shown on the left. The radiologist identifies an indeterminate liver lesion that was not seen on prior unenhanced studies. There has also been interval development of steatosis. If you look carefully at the CT from a year ago, the lesion was actually there. To further evaluate the indeterminate liver lesions, an MRI is performed. The liver lesions are characteristic of hemangioma on every sequence, but the interpreting radiologist says they are suspicious for metastases because they are new. He is affected by anchoring bias. If you look at the T2 weighted image on the left, it is T2 bright, and on the post-contrast images on the right, there's peripheral nodular discontinuous enhancement that fills in on the equilibrium phase. In retrospect, the lesions were present on prior unenhanced CT and on more remote enhanced CT examinations from 3 years ago. Diagnostic errors involving cancer can have significant implications, and employing prospective double reads for cancer patients or potential cancer diagnoses can have substantial value for patients. Procedure requests are also another opportunity to incorporate double reads. This is a CT performed for abdominal pain, which reveals an enlarged lymph node in the right lower quadrant on the image on the left, and the interpreting radiologist recommends a percutaneous biopsy. The radiologist reviewing the procedure request looks through the study again and identifies a mass in the terminal ileum that the original radiologist missed. This is shown on the image on the right. He talks to gastroenterology, who performs a colonoscopy and biopsies the terminal ileum mass, and pathology demonstrates metastatic melanoma. Reviewing procedure requests is an opportunity to identify diagnostic errors, or a missed opportunity if requests are not reviewed appropriately by radiologists. This is a CT performed in a patient with right lower quadrant pain and fever. The interpreting radiologist identifies a tubular structure in the right lower quadrant with wall thickening, edema, and associated fat stranding. The tubular structure appears to be decompressed on the coronal images without an associated fluid collection. Something didn't seem right, and this radiologist did the right thing. He asked a colleague. The colleague looked at the exam and said that he thought the wall thickening was actually peritoneal fluid, and this was likely a perforated appendicitis. The patient went to surgery, and pathology demonstrated a normal appendix, shown on the left-sided image, and a Meckel's diverticulum. The point here is that even though double reads and consulting colleagues can reduce diagnostic errors, it will not completely eliminate diagnostic errors. To summarize, there are multiple opportunities to incorporate second opinions into routine clinical practice to help radiologists avoid diagnostic errors. Tumor boards and multidisciplinary conferences already incorporate double reads. We always have the option of consulting colleagues for complex or difficult cases, or consulting colleagues in other specialties. Areas where getting second opinions can be particularly important is cases involving cancer diagnosis, staging, and restaging. Procedure requests are also another opportunity for double reads, and one significant opportunity to reduce diagnostic errors is to establish a formal process for prospective double reads. While second opinions will not eliminate diagnostic errors, incorporating second opinions for a subset of cases will likely reduce errors and improve patient care.